Good afternoon, everyone. I would like to welcome you to our webinar on governance for strategic purchasing, transition between paradigms, the example of Cambodia. The webinar is part of a series which is co-facilitated by WHO and Results of Development, and we are using the collectivity platform for this. So for those who haven't been connecting yet and who don't know the collectivity platform yet, we would really like to encourage you to have a look at it. It is open to everyone who is interested in collaborative learning and knowledge sharing, and it proposes a range of communities and projects focusing on different public health topics. You'll find a link to our project on your screen. And on the project website, you can sign up for the project to be sure that you receive all the latest news, but you will also find the presentations and recordings from previous webinars. Now to our today's webinar, we will hear about strategic purchasing in Cambodia and the ongoing reforms, which will also propose changes to the governance arrangements. Dr. Veasnakiry, the Director of the Department of Planning and Health Information of the Ministry of Health in Cambodia, will share his experience. Following his presentation, Christopher Fitzpatrick, Technical Officer in the WHO Country Office in Lao PDR, will share his reflections and explore similarities and differences between the two countries. After the presentations, we will open up for questions and discussion. One last housekeeping rule, I would like to kindly ask you to keep your microphones on mute during the presentations. And with this, I hand over to Cambodia.
Okay, good evening, everyone. So now I would like to share some of the information with regard to the strategic view, which is from the government viewpoint, and also the ongoing effort for the strategic purchases. Again, this slide is to show you the governing structures for the purchasing of the services by the different social architecture scheme. One is the allocated fund, the scheme for the provide the support to the poor who access to the health services with free of charge. Until the scheme has been led by the MDGs and also the financed by the national budget and also contribution from the partners. And the other scheme is the National Social Security Fund for Care. This scheme has covered by the has covered the public civil servant, the patriot and the public civil servants, and also the cover the private employee and the worker in the private sectors. For the equity fund, the operations manage the scheme and also the from the financing fund, basically is the subsidized scheme from the national budget, and also we contribute from the partners. And the services the purchase from the public or public health facilities throughout the country at the primary level facility as well as the hospital on the charity levels. And the fund beneficiary is the poor households which are eligible through the pre-identification of the poor and also the post-identification at the facility levels. For the National Security Fund for Health, the services that we purchase from both public and private health facility, and the services that the package for the National Social Fund for healthcare for both the civil servant and the private, the employee and the worker is slightly different from the benefit package for the fund beneficiary. This is a snapshot of the population covered by the current social protection scheme. In 2019, the total population of Cambodia is around 16 million and 16.5 million. And the coverage by the National Security Fund for the private employees and the worker and civil servants cover up 2.2 million members, while the AK Fund for the poor cover around 2.4 million of the poor. And the services have been purchased from the total number of public facility now from the December 2018 is almost the 1,005 facility. And the private facility is the 12,000, not only around 50 private facility has been contracted by the National Security Fund to provide services for their members. And the NSS for healthcare for the private employees and the has started in 2016, while the service scheme started in January 2018. The agri fund will go almost more than 15 years. It started in 2000. In terms of the social arrangement for the currently the agri family by the and there is no contract between the innovation and public providers. But the agri fund, the claim processing has been verified by the third party, the government institution, the payment service agencies. For the civil servants, for the National Security Fund for the civil servants, for the private employee and the worker is managed by the National Security Funds. And this fund is governed by the governing body. It is which consists of the representative from the state of farming, from the state of labor, from the state of health, from the employers, and also from the users. So in terms of the contracting arrangement, the fund has been contracted for public private facility, facilities, and also the manage the internal claims and the legal management. For the public budget, the basic budget to support the CBP is based on correlation between the small finance and the citizens of for the future, according to the national social policy framework for the social protection system 2016 to 2025. All the social protection scheme, such as the fund and the others, so National Security Fund for healthcare will be managed by single payers. And the single payer is likely to transform the current National Security Fund to the new entities. And in terms of the fund flow, through the single payers, this also the public budget and PVC will be subject for the candidate futures. In terms of the financing, as I mentioned, the fund is fully subsidized and fully funded by the government budget with contribution from different partners on the line item budget within the innovation budget. And for the NSS, for the social, for the NSS, for the civil servant, as well as for the private employees, by law, the contributory scheme will be 50%. petition from the employer and petition or petition from the citizen and petition from the government. Currently, the civil servant scheme is fully financed by the government budget, while the private employee and the worker has been fully financed by the employer since January 2018. In the future, the fund will continue to finance by the public budget and the service scheme as well as the private the employee and worker scheme will be based on the contributory schemes. One of the particular important the coverage of the middle message middle will be the single releasing scheme or the new scheme from the year on. They particularly refer to the informal sector populations that the country need to work out in the next 5 to 10 years time, or what kind of the social insurance tax to provide for the informal sector populations. In terms of the provider payment mechanism for the refund, we use the cash-based payments both the primary and the secondary and tertiary level of care. And the payments of the cost has been calculated or based on the one-time costing study and related by the Ministry of Health. While the civil servant and private employee and the worker scheme, they also use the cash-based payment plus fee for services. And the costing and all the data has been based on the actual analysis, and also the payment for the public. They have the pay 100%, 150% to the public facility who have provided outstanding qualities of services. And the budget item is to support the overall facility performance across the system based on the annual budget allocations. For the future equity fund, I think will be based on the routine the activity to reform the city. Currently, I'm working on a service system for the facility costing on the regular basis. For the service event, we continue the service exam we come for setting the fee level of the field services as well as for the private worker and the private employee and the private workers. From the budget, public budget viewpoint, we also consider it the budget is also reaching from by taking into account the additional factors. For example, the percentages of the level of the poverty of the geographical setting, and then we could go along the line with the public financial management reform currently of the government. For the providers, so far we can find that the benefit package has been provided by more than 14,000 public health facility. And for the civil servant scheme and the private employee worker, they also provided by all of the public health facility across the country. Where the public, by the private sectors, the number of private sector contracted with the fund in reduced form. And the national public budget has been allocated to drop the level of the facility across the country. For the future, I think the fund, the fund will be transformed under the management and the application of single pages, and then whether the fund can be the package for the fund can be changed for the private sectors and also. For the service server, I think the private sector is already contracted to provide these services. For the public budget under the single payer, I think we can discuss specifically the what to be financed from the supply side and what should be financed from the demand side. And this will be identification of the financial structures at the facility level. For the benefit package, I think the benefit package for the refund, we have the define the benefit package for different level of the high facility, for example, the benefit package for the primary level health center, and benefit package for the hospital level, we call the complementary package for activity. For the Switzerland, the same, they define the benefit package based on the minimum benefit package for the health center, and also the complementary package for health services at the hospital and hospital levels. So for the budget, the public budget, we also use the the package or activity as well as the complementary package activity to guide the budget public budget allocations. In the future, I think we also will develop the guarantee or the whatever is fairly basic or decision package across the different social protection scheme. So I think we basically simply saying that whether we in the future we opt for the uniform benefit package across the different social protection scheme. And then we can add on the benefit package according to the financing of the scheme. For example, for the security scheme, maybe we can use we can add on more benefit package. So this is referred to the supplementary package. So based on this prospect, based on the financial situation of the different scheme for the different target group. This is the final part of it. This is the future institutional arrangement according to the national social policy framework for the social protection systems. So I think you can see the board of the I think at the government level, we not included in this figure, but we already established the National Council for the Social Protection System, which will provide the direction, strategic direction, and also oversight the implementation of the social protection schemes, including social protection schemes. And then below the National Council for Social Protection Scheme, we have the Executive Committee, which is the technical arm to support the Council with regard to the policy, strategies, development and also monitoring the scheme. At the executive level, it is a single payer, it can be called the National Social and social security funds, and then we have the number of the scheme and the management and application of the scheme like the equity fund that they transform from the currently managed by the wage to the single payer access. We have the health insurance for the informal sector that the country will pursue in the next 5 to 10 years. And also we have the health insurance or the social natural security fund for healthcare for the government civil servant, employed, and also for the private party. So I think this is, and then for in terms of the provider of the services, we can, as I mentioned, we can it will be the same, the public and the private sectors. And what is the issue we need to discover that the fund should be, the package should be purchased from the private sector at large. And in 2015, we already have the fund different scheme for the different target group. And in terms of financing, I mentioned that the fund will make the tax-based financing with government subsidization, because the scheme is benefit for the poor or the financial remove the barrier intervention access to services for the poor, while they have a scheme like the scheme for the civil servant and the private employee, they remain the contributory scheme by and for the claim processing, the fund currently, as I mentioned, is the claim processing has been verified by the third party before they reimburse, before they reimburse the fund to the facility. Whether they have respond the role of the PCA, the certification and the verification agency to certify the claim for the National Security Fund for the civil servant and for the private employee for the and the local institutions. Okay, so now here let me finish some presentations. Thank you for your time and attention.
Thank you very much. We really appreciate your presentation. It was very comprehensive. It showed very nicely the current and the future situation. And we're also aware that it's already very late in Cambodia. So thank you very much for still being with us. With this, I will then hand over to Christopher for the comments.
So thank you to Dr. Kiri for this thought-provoking presentation. So I'm pleased to have the opportunity to offer some of my own thoughts based on what I saw in the slides and also based on what I've learned in a little over a year now in Lao PDR. All of this with the disclaimer that any of the errors in what I'm about to say are my own. It strikes me in looking at the presentation from Dr. Kiri that the structure of purchasing in Cambodia today looks very much like that of Lao PDR before 2016, when MOH provided input-based budget support for fixed costs of staff and equipment, plus recurrent costs for public health activities, while other schemes made output-based payments for the variable cost of treatment. These schemes included a national social security fund, which covered the civil servant and private employees. It was overseen by the Ministry of Labor and Social Welfare. Also, the health equity funds covering the poor, plus a free MCH scheme for pregnant women and children under 5 years. This was overseen by the MOH. Finally, voluntary community-based health insurance, which in the Lao context never covered more than about 3% of the population, also covered by or overseen by MOH. In 2016, a process of defragmentation began with the rollout of a non-contributory tax-based national health insurance, or NHI, for the informal sector. This replaced health equity funds, replaced the free MCH program and CBHI everywhere except in Vientiane capital. It is similar to the Thai UCS scheme, those that are familiar. This is overseen by the National Health Insurance Bureau within the Ministry of Health. In 2019, so just this year, there was further defragmentation with the merger of the NSSF, the formal sector scheme, with NHI under the Bureau. The Bureau receives a transfer corresponding to 1.25% of the 1.5% that is paid by employers and employees for the health benefit of the NSSF. While funds are pooled by the Bureau, it will continue to report separately on the utilization and benefit of NSSF members. This will be monitored because it is not yet clear really what the direction of the subsidization will be. In some respects then, the current reality in Laos looks a little bit like the future vision for Cambodia. So what aspects of the Lao paradigm shift, if I can borrow that term, might be instructive? In transferring management of the formal sector health contributions to NHIB, payment methods and benefit design were largely harmonized. So there's harmonization in provider payment a shift in provider payment from capitation for the formal sector scheme to a mix of both capitation for health centers and all consultations and case-based payment for hospital admissions. There was also near harmonization of the entitlements for both the formal and informal sector schemes. For example, the formal sector scheme actually had limits on dialysis and excluded health centers, did not provide any choice in domestic provider, but as far as I understand, did cover some services abroad. In this harmonization, the benefits of the NSSF members were topped up, but not leveled down. So any benefits, any additional benefits were maintained through this near harmonization. There was also near harmonization of obligations, with the only major difference being that contributors to the formal scheme are exempted from any co-payment. This near harmonization is in contrast, I think, to the vision expressed from what I saw in the slides for Cambodia. But given the original title of the seminar I will focus actually on the question of the purchaser-provider split. One could say that defragmentation in Lao PDR came at the cost, in inverted commas, of the institutional purchaser-provider split that had existed for the formal sector scheme under the Ministry of Labor and Social Welfare. Now, I mean, NHIB is in fact situated within MOH, as I may have mentioned, has the status of a department. It doesn't have direct control over provincial and district health insurance bureaus, as these belong to the structure of the provincial and district health offices. Healthcare providers are owned and directly controlled by MOH. Bureau offices at the national, provincial, and district levels are identified as the secretariat for the respective management committees for the health insurance. But these committees are chaired by MOH, in addition to members of provincial and district level governments. So while these bodies create a platform for engagement of various stakeholders, they also, in a sense, double the control function of MOH offices over the respective HIB offices. Given limited staff and weak information systems at facilities, the district and provincial health insurance bureaus are, in a way, limited to the role of checking invoices at the facilities. That's which takes up an enormous amount of time. NHIB essentially requests payments for service provision from the Department of Finance within the Ministry of Health. It's worth noting perhaps that in at least one district hospital that I visited, the limitation of staff meant that the financial officer for the District Health Insurance Bureau, the District Health Office, and the district hospital was the same person. This is recognized as an issue and is becoming rare, I would say. So I'm aware of the arguments in favor of a purchaser-provider split, namely a stronger or more credible focus on efficiency. But in listening to the earlier presentation and thinking about my remarks here, I also considered the arguments against the purchaser-provider split, namely costs of contracting and coordination. In Lao PDR, even without an institutional split, coordination costs are a challenge. For example, at information systems. Though the main arguments, I think, against institutional split would probably be management capacity with limited staff within the NHIB, but also the importance of maintaining MOH stewardship. Also, in listening to the earlier presentation, I think about distinctions between splits in institutions and between splits in functions. Recalling that there can be, in fact, a split in functions, even if there isn't a split in institutions. So the National Health Insurance Bureau allows a separate department or office within MOH, has its own budget for provider payment, or had its own budget for provider payment in 2016, 2018. In 2019, and it seems in 2020, that budget will be included as within the chapters of the MOH budget. But I'll come back to that in a moment. But the Bureau also pays providers for variable costs separately from the MOH budget for fixed costs in 2016 and 18. So current policy discussions in Lao PDR include developing a policy framework for increasing hospital autonomy, strengthening MOH stewardship in prioritizing an essential health service package and accrediting providers for quality, strengthening the strategic use of information by the National Health Insurance Bureau, creating a special bank account and a reserve fund, much in the way that the NSSF had, to ease fund management and provider payments by the NHIB. And picking up on my earlier point, starting in 2021, I understand that there's discussion about piloting in a number of provinces a separate NHIB budget for all the chapters, including staff salaries, NHIB staff salaries, in addition to the provider payment funds. Not yet part of the discussions that I have heard anyway, but conceivable for the future is that after years of building capacity and setting up, implementing rules and procedures for NHIB, a process could be initiated towards autonomy, autonomous organization. And in the even longer term, as the population ages, one could imagine that the merger then of NHIB and NSSF offices would provide a fully integrated package of health and social care benefits. In conclusion, I will just leave you with the thought then that maybe, much like strategic purchasing more broadly, the fine-tuning of this purchaser-provider split is a gradual, iterative, and continuous process. Thank you for this opportunity.
Thank you very much, Christopher, for sharing your thoughts and then also the outlook on the Lao Cambodia situation, and also mentioning very pragmatic implementation issues such as health information systems and capacities. With this, we will now open up for questions. So you have the possibility of unmuting yourself and then asking your question, but then you also have a chat function in which you can put questions if you prefer. Anyone has any comments or questions they would want to share?
I have maybe a question if I can come in. This is Inka Matau from Geneva, World Health Organization. First of all, many thanks for the really great presentations, both on Cambodia and also the reflections from Laos. Really appreciated it, very clear. Actually, I would like to pick up this issue about costs of a real purchaser provider split, like when you have an institutional provider purchaser split versus a functional split, let's say within the Ministry of Health. And I would really like us to sort of explore further the costs of, coordination versus the potential benefits of increased efficiency when you actually have that split. You can engage in contracting, you can apply possibly more output-oriented payment methods. So yes, of course, setting up a separate purchasing agency implies additional administrative costs, and studies and also the National Health Accounts data shows well, not so much. Well, also the national health accounts data is a source of that. It shows that the administrative costs are a bit higher in a social or in a health insurance scheme. But I think we also have to really carve out and be aware of the potential efficiency gain. So yeah, I don't really have a specific question, but it's just a point that I would put on the table and hear from others how they see that in their country. Thank you.
Okay, I just share some of my thoughts with regard to the issues around the costing and the package. And I think as I mentioned, that the big package and the costing that the users so far saw as is supported by the costing study. But now the evaluation with the portfolio of the show, we work very closely with the visual content team to define the package. How we want to move to use the uniform package called the sociality the protection scheme, and then the package will be supported by the costing exercise. So I think the starting point for the defined package, we come up with a certain criteria how we define the package, and then the criteria will be discussed in the next week with our key stakeholders, including the ministry, the agency who involved in the social action systems. And then maybe the costing. And currently we have the other panels, the uncertainties or the way to do the costing of the services at the primary level and as well as at the hospital level, in order to inform the costing of the benefit package. So I think this is the ongoing activity or ongoing effort that we want to move closer. So with the evidence-based, with package design, which reflects to the burden of the disease or whether Cambodia is facing now and also in the futures. And in terms of the costing, we also will look at what are the fiscal space would have within the next 5 to 10 years.
I think if this is Eric from WHO Cambodia as well. I think building on what Dr. Kiri has said, there has been as you saw in the other diagram on this one, the earlier one, there's kind of a fragmentation around the governance of the definition of benefits and of provider payment currently. And this work that we have ongoing right now is looking at harmonizing that and bringing it all under one roof. I think to kind of respond a bit to Inka's question, I mean, I think the costs versus the benefits of having a purchaser-provider split, I think that's an interesting question. I think actually here in Cambodia we have some interesting developments coming up. Maybe Dr. Kiri wants to share a few words about this. There's a purchaser-provider split that's potentially in the offing here in Cambodia, but actually coming from a different direction, which is namely that there's a process that's been going on for quite some time around decentralization. And there's been a lot of thinking that's been going on around decentralization. And it looks possible that next year that the management of subnational health facilities, that is those that are based in the provinces and not national level hospitals, will be, the management of those will move to the provincial governors. And so in that sense, there will be a different split. But some of the in purchasing will remain at Ministry of Health through Health Equity Fund and at the National Social Security Fund as well. So actually what we have here in Cambodia is sort of a different type of purchaser-provider split that also I think has been seen in in other countries such as Kenya and others in the last few years. I don't know, Dr. Kiri, if you have any thoughts you want to add on what a new perspective that will provide. It's very early days right now. We don't know exactly what that will look like. So anyway, just for discussion.
Thank you very much for these clarifications and also for raising the issue with decentralization, which I think in many countries adds a kind of additional layer of complexity, which we have to consider. Are there any other reflections or comments?
Hello, this is Syed Al Junid here from Malaysia. I want to get a bit more detail on the payment method that being used in the system in Cambodia. I think the speaker mentioned about the case rate. Can you elaborate a bit more? How does the case rate are being operationalized, and how do the case rate are being decided upon?
The case-based payment has been developed by the what we call the teams, the working group. The working group, we can see some ministries of disease of health, the National Institute of Public Health, and also the team from the National Security Fund, as well as from the Ministry of Finance. So the package has been reduced based on the minimum benefit package for the health services that they defined for the health center, and also review the complementary package of activities defined for the different hospital levels. So the team work on use that to benefit package to come up with a defined benefit package for the social social security fund for healthcare, as well as for the health fund. But for the health fund, we the one of the team typically provide planning information. We work with also the relevant stakeholder to define the benefit package for the health fund. And then we use that benefit package, the cost that benefit package based on the costing study that I've already mentioned. That the costing study, we look at the unit cost, and basically we use the unit cost for each of the services to inform the defined level of the fee or the fee schedule or the fee schedule for those packages. For the NSS benefit package, we also the NSS also have a technical support from the actuary who will do the costing or the detail and then propose this cost for the benefit package.
Thank you. Thanks for the explanation. Thank you so much.
Do you have any other questions or comments? And if no other questions are there, maybe I could ask a question more about clarifications, because what I find very interesting is that in many countries you might have also a kind of different interest represented, which I think is not necessarily purchaser-provider split, but then if you look at how decisions are taken regarding health insurance provider payment mechanisms, benefit packages, and so on. And I think often those decisions are taken by board of directors of their respective purchases. And I think those boards can be a framework or an arena where you have different interests represented and where there would not just be maybe Ministry of Health, but also other ministries as well. So in the case of Cambodia, I saw in the presentation that you have the board of directors of the Social Security Fund. But are there also different ministries represented? Would there be providers represented? Or would there also be participation of beneficiaries? Would it be possible to elaborate a little more on this?
For the moving from different before the board of directors is executive at the executive levels. So about the board of directors is the governing body. So the governing body is currently care for the private employee and the private employees, which include the representative from the Ministry of the Labor and Ministry of Economic Finance, Financial Ministry, and then the representative from the employers and also the representative from the employee. This is represented by the unions. And the for the and also the representative from the councils of the ministers sitting in the governing board. And for the civil servant, we have only the representative from the different ministries. So when we move to the single the payers setting, so the governing councils will be comprised of the different stakeholders, and then it might include the representative from I think we already have the thing from the key stakeholders like the employers, like the employee, the by the institution, and the government, the administrative agencies.
Thank you very much for the clarifications. Are there any other questions, comments? Otherwise, I will close the webinar and also want to thank you very much for your participation. Also, if for some of you it was very late in the day already. This was the last webinar from our side for this year, but we plan already to continue to propose webinars around strategic purchasing next year. And also, in addition, similar to previous collectivity projects, we also plan to collect different country experiences around governance arrangements for strategic purchasing. So this we will take from the webinars which have been presented, but we will also engage other people who signed up in our collectivity project. So we will share information on this within the next weeks through the collectivity platform. So on the collectivity project website, which you had a link in the invitation, and we will also share it again with the presentation from this webinar. So if you're interested in participating, please sign up so that you will be sure to get all the latest updates. So with this, I would like to thank you very much and wish you all a nice rest of your day. Thank you.
Thank you.
Thank you.
Thanks. Bye-bye.
Bye.
Have a good day.
Really